Hello and welcome to another episode of Health Matters. I'm your health coach, Dr. Michael Chillemi. And on this episode, this is part three of our series on understanding osteoarthritis. So in this series, in this part, we're going to be talking about understanding facet joints, facet arthritis, bone spurs, spinal stenosis. So we're going to be really welcoming you back into the ultimate deep dive into osteoarthritis. So let's recap a little bit. In part one, we spent our time understanding what osteoarthritis actually is. We discussed how a healthy joint functions. We explored the remarkable anatomy of cartilage, like synovial fluid, ligaments, muscles, and bones. And then we followed the disease from its earliest microscopic changes all the way through inflammation, cartilage degeneration, bone remodeling, and pain. So now we're going to focus on one specific area of the body that I see every single day in practice, the spine. This is one of the most misunderstood areas of osteoarthritis because many people assume arthritis and degenerative disc disease are exactly the same thing. That cannot be further from the truth. They are not the same thing. Although you will hear them a lot together as they involve different structures, different biomechanics, and sometimes different treatment approaches, but you do hear them of occurring together. So understanding the difference is essential because it changes how we diagnose the condition, how we explain to patients, and ultimately how we decide on the best treatment program for you, the specific patient. So let's begin by looking at the anatomy of the spine. When most people think about the spine, they imagine a stack of bones stacked up on top of each other. While that's technically true, the spine is actually one of the most sophisticated mechanical systems in the human body. Your spine contains 33 vertebrae. 24 of those vertebrae remain movable throughout life. Each vertebrae has several important responsibilities. It protects the spine. It supports the weight of your body. It allows movement, and it provides the attachment points for muscles and ligaments. Between each vertebrae sits a intervertebral disc. Many people assume these discs are joints. Technically, they are, but they're very different from the joint associated behind them. Each spinal segment actually contains three joints. One, the disc in front, and two facet joints in the back. This becomes extremely important because osteoarthritis primarily develops within the facet joints, not the disc itself. So let's dive right into it. Degenerative disc disease versus osteoarthritis. This is probably one of the biggest misconceptions, again, that we see and people say. I see patients that come in and someone comes into the office saying, my doctor told me I have arthritis. I look at their MRI. What they actually have is degenerative disc disease, which is not the same diagnosis. Let me explain why. Degenerative disc disease primarily affects the intervertebral disc itself. The disc is composed of two structures, the outer part, which is called the annulus fibrosus. Think of it as a multiple layer of incredibly strong collagen fibers wrapped around each other. Inside the middle of that sits the nucleus pulposus. It's a soft gel-like center composed largely of water. When we're young, these discs are incredibly hydrated. They absorb shock beautifully. They distribute forces evenly through the spine. But as we age or after an injury, the disc gradually begins to lose water. This process is called disc desiccation. All that means is it's dehydrated, it's lost water. As the water content decreases, the disc becomes thinner and thinner and thinner, less flexible, less capable of absorbing shock. Eventually, the disc loses height. That is degenerative disc disease. Notice some something important in that part. This process is occurring in the disc itself, not the facet joint. Osteoarthritis is different. Osteoarthritis primarily affects the facet joints, which are located behind the disc. The cartilage covering those joints, covering the facet joints, are deteriorating. The underlying bone remodels. Bone spurs develop. The joint capsule thickens. Inflammation develops. That is what osteoarthritis is into the facet joint. Although these two diseases frequently occur together, they begin in completely different structures. So if they're different diseases, why do almost always see them together? The answer is biomechanics. Imagine building a table with four equal legs. It stands perfectly level. Now, you shorten one of those legs, and now you're going to be a little bit uneven, right? The weight shifts. The remaining legs must absorb far greater forces. The same thing happens inside your spine. As the disc height decreases, it gets smaller. The facet joints then become overloaded. Instead of carrying their normal share of the body's weight, they begin absorbing much greater mechanical stresses. That excessive loading gradually damages the cartilage that cover the facet joints. The body responds exactly the way we discussed in part one. Inflammation develops. Chondrocytes become overactive. Bone remodels. Eventually, the facet joint osteoarthritis develops. So degenerative disc disease doesn't automatically cause arthritis, but it creates an environment where arthritis becomes much more likely. So let's understand the facet joint and spend some time discussing it because it is one of the most overlooked joints in the human body, right? The facet joints, they they help every movable vertebrae form two facet joints with the vertebrae above and below. The two of them form the facet joint. They are true synovial joints. So just like your knees, just like your shoulders, they contain articular cartilage, a joint capsule, synovial fluid, synovial membrane, supporting ligaments, and they also have pain-sensitive nerve endings. Everything we discussed in part one applies here. The facet joint, they have one primary responsibility. They guide spinal movement. Think of them as railroad tracks. They ensure that each vertebrae moves along the correct path while preventing excessive motion. Without healthy facet joints, your spine would become unstable. You'd be like one of those guys you see outside the store that wiggles back and forth. That's what your spine would be like. So you need your railroad tracks per se, your facet joints to help you um, become stable. So think about them every time you bend, twist, reach, or lift. The facet joints help you control that movement. Unfortunately, they absorb a tremendous amount of mechanical stresses throughout life. They also one of the first joints in the spine to develop osteoarthritis because they have a lot of movement there and a lot of responsibility. So what actually happens to these facet joints inside them? The process follows the same biological cascade that we learned earlier. Basically, you have healthy cartilage that begins experiencing excessive stress, right? The chondrocytes detect injury. Now it's going to say, hey, let's send some anti-inflammatory. So it's going to send inflammatory cytokines. They're going to increase, which then causes the protoglycans to disappear. You need protoglycans. They're important. Collagen again begins to break down. The cartilage surface becomes rough. So instead of being smooth, it becomes rough and rocky. Not really rocky, but it comes rough. The joint space gradually narrows. Meanwhile, the underlying bone begins to thicken. The capsule surrounding the joint becomes thicker and stiff. Eventually, bone spurs begin to develop around the joint margins. Doctors refer to this as facet hypertrophy. The joint literally becomes larger. This enlargement may seem insignificant, but inside the spine, every few millimeters can make a tremendous difference because nerves travel through incredibly small spaces. When those spaces begin to narrow, symptoms begin to appear. So when we're talking about narrowing, that's going to lead us into talking about bone spurs, nerve compression, and spinal stenosis. So basically, at this point, we understand that facet joints are true synovial joints, and just like the knee, hip, they can develop osteoarthritis. But here's where spinal arthritis becomes unique. Unlike arthritis in your knee, the spine has one additional responsibility. It has to protect the spinal cord and every nerve that leaves the spinal column. That means even relatively small arthritic changes can begin affecting the nervous system. This is why arthritis in the spine often produces symptoms far beyond simple joint pain. Patients may experience numbness, tingling, weakness, burning pain, or even difficulty walking. So, how does this even happen? Let's follow the process. One of the most common findings patients are told is when they look at an x-ray is that something is called an osteophyte. You have an osteophyte or you have a bone spur. The moment patients or people hear the word bone spur, they imagine a sharp, dagging bone poking into the surrounding areas. That's actually not what a bone spur is. So let's think of this. A bone spur is the body's attempt to stabilize the joint. That has become typically unstable. Remember what we learned in part one. As the cartilage breaks down, the joint loses its normal structure. The body tries to compensate. One of the ways it compensates is by laying down new bone around the edges of the joint. Think about someone trying to stabilize a wobbly table. One solution might be to make one of the legs wider. The body does something very similar. It increases the surface area of the joint in an attempt to spread the forces over a larger area. Initially, this is a protective action. Unfortunately, what begins as an attempt to stabilize the joint often creates new problems. So you think about it, as your biomechanics change, the forces that your body is supposed to take changes. Your joints themselves can't handle it. So if you have a normal square bone like this, maybe that square bone now becomes more rectangle, and you're going to see it, you're going to start to dip down, right? The edges get longer. The bone spurs start dipping down. That's where we start to have problem. So the spine contains those very little extra spaces. And when we're talking about it, the spinal cord that travels through the spinal canal, individual nerve roots come out of those small openings, right? And that's called the neural foramina. Those openings are typically only large enough to comfortably accommodate the nerve. Now imagine adding extra bone around those spaces. Even a few millimeters of additional bone growth can begin to narrow the space available. At first, the nerve may simply become irritated. You might have some occasional stiffness, some mild pain, intermittent tingling. As the narrowing progresses, symptoms become more frequent. Eventually, the nerves become compressed. When this occurs, patients often experience pain traveling into the arms or legs, numbness, weakness, or changes in sensation, depending on which nerve is involved. So that's critical to understand. As your bone is changing because your biomechanics are wrong, your biomechanics are off, your forces on your joints are off, your body's reaction is, hey, let's lay down more bone, let's stabilize, let's make things better, right? Let's widen the foundation of that joint to make it better. Sounds good in theory, but over time, that theory becomes your biggest problem. Understanding the neural foramina. So let's get into it. Let's take a little closer look at that. Every single nerve that leaves the spinal column through one of the openings And you're going to think of it as a tunnel, right? So the nerves exit the neural foramina as a tunnel. Um, Before traveling to muscles, skins, and organs throughout your body. So it's basically going through the tunnel and going out to your muscles, skins, and organs. When we're young, the tunnels are wide open. You got big old tunnels and there's plenty of room. But as arthritis starts to develop, the tunnel gets narrower and narrower and narrower, and that's reducing the space. Bone spurs may develop around the facet joints. The disc may lose height. The ligaments surrounding the canal may thicken. The facet joints themselves may enlarge. Each of these changes alone may seem minor, but together they're gradually shrinking the tunnel where the nerve must travel. When that happens, that's called foraminal stenosis. So you can think of it having a big tunnel. You start adding problems, start adding problems, start adding problems, start adding problems, right? Now you've gotten your foramina so small that you're compressing it consistently, right? You might have moderate stenosis, mild stenosis, severe stenosis, depending on how much changes you have in that area, and your body has to adapt to those changes. So basically, the word stenosis means narrowing. So one of the bigger areas that we're going to talk about is, which is it's associated with osteoarthritis, is central spinal stenosis. Instead of narrowing the openings where the nerves exit, central stenosis refers to narrowing of the spinal canal itself. Remember, the cord travels through this canal before branching out into individual nerves. When arthritis progresses, several changes occur simultaneously. Bone spurs enlarge, facet joints become hypertrophied, the disc loses height and may bulge. Another important structure that begins to change is called the ligamentum flavum. The ligamentum flavum is a strong elastic ligament connecting one vertebrae to the next along the back of the spinal canal. Its primary job is to help maintain the spinal stability while absorbing smooth movement. When we're young, the ligament remains thin and flexible. However, over many years of abnormal stress and arthritis, the ligament gradually becomes thicker. Doctors call this ligamentum flavum hypertrophy. All it really means is it got bigger, right? The ligament got bigger. That's all it really means. So the thick ligament now begins bulging inward toward the spinal canal. Remember, bone spurs are already taking up space, and large facet joints are taking up space. Disc bulges may be present. Now the ligaments begin to take up space as well. Eventually, the spinal canal becomes significantly narrowed, and that's the problem with spinal stenosis. So one of the classic symptoms that you would see with a patient with lumbar spinal stenosis is something called shopping cart syndrome. So if you ever saw a person that stood up straight and they started walking, they started leaning forward, right? They lean forward, and the reason they're leaning forward is because it feels better for them to lean forward. They say, I can walk farther if I'm leaning over a shopping cart, right? Or it doesn't hurt as much because they're bent over. Why does that happen? When you bend forward, the spinal canal actually becomes slightly larger, right? You're bending your spine, so you're opening up and changing your biomechanics in there. So the ligamentum flavum stretches, right? So as you bend, you stretch those ligaments, and therefore the pressure decreases on the nerves. Symptoms temporarily improve. Standing fully upright or leaning backwards has the opposite effect. The canal narrows, pressure increases, pain often returns. This is one of the classic clinical clues to help us recognize spinal stenosis. So not every patient with spinal arthritis develops nerve compression. Some develop a different condition called facet joint syndrome. Remember, facet joints themselves contain pain-sensitive nerve endings. When arthritis causes inflammation inside the joint, they become painful. Unlike a herniated disc, which often causes pain traveling down the arm or leg. Facet joint pain usually remains localized. Patients commonly describe pain when standing, pain when leaning backwards, pain when twisting, morning stiffness, difficulty getting out of bed, pain after prolonged standing. The joint is often worsened after periods of inactivity and improves somewhat once the joint begins to move. This pattern becomes very helpful during physical examination, right? So movement is life. Don't forget, you got to move. Got to keep those joints moving. Got to keep those joints lubricated. One of the things patients tell me most often is that they don't feel like themselves anymore. Simple tasks become pretty exhausting and overwhelming. Looking over their shoulder while driving becomes difficult. Standing to cook dinner becomes painful. Walking to the grocery store requires frequent rest breaks. Playing with grandchildren becomes harder. Sleeping comfortably, which is something they enjoyed, becomes harder. Over time, people begin avoiding activities they once enjoyed, not because they don't want to, but because their movement becomes associated with pain. So pain equals not doing it, right? So unfortunately, less movement leads to weaker muscles. Weaker muscles increases stress on the joints. More stress leads to more pain. The cycle continues. Breaking that cycle becomes one of our primary treatment goals when we're treating you. Okay, so that's going to lead me into one of the most important parts of evaluating spinal osteoarthritis is diagnosis, right? We got to make the right diagnosis. One of the biggest mistakes I see in clinical practice is waiting far too long to understand what exactly is happening structurally. Patients often spend months and months, sometimes even years, treating symptoms without ever understanding why those symptoms developed in the first place, what's going on. And I think the one reason I believe it's happening is because imaging really does play a huge role, especially early on in the evaluation process, to understand what's going on with the patient. I always say, I want to know what I'm treating. I don't know what your spine looks like. I don't know what's there. I want to make sure there's no problems that's going to preclude me from helping a patient get better. Or if there is something there, I want to make sure I'm doing the right treatment plan from the beginning and not learn about it 8 weeks later, 10 weeks later, 12 weeks later. Because then I've already treated you X amount of times without doing the right thing for that patient. And that doesn't never sat well with me. So when a patient presents with persistent spinal pain, restriction of motion, and symptoms suggesting structural degeneration, I want to understand the mechanics of the spine, and an X-ray is going to give me a valuable information. It allows us to evaluate the spinal alignment, the disc height, the facet joint arthritis, bone spurs, joint space, spinal listhesis, whether you have a scoliosis, maybe you have a curve change, degenerative changes, and overall biomechanics. I always tell my patients, I don't order x-rays simply to order x-rays. I want to understand what you look like inside so I know how to treat you the best way possible, right? I want to understand the functionality of your spine and understand the structure so we can develop the best treatment plan and find the biggest root cause, underlying cause, not just the symptoms. Symptoms plus function plus knowing the eyesight view of what your spine looks like is the golden ticket to understanding how to treat patients the best way, in my opinion. So now that we've answered some of the biggest questions surrounding spinal osteoarthritis, we've learned that arthritis and degenerative disc diseases are not the same, right? Let's recap it real quick. Osteoarthritis is in the facet joint. Degenerative disc disease is in the disc itself. We've seen how facet joints develops arthritis. We've followed the formation of bone spurs. We've explored spinal stenosis. And we've discussed why early structural evaluations can provide important, valuable information. We're going to get into bringing a lot of this together in our next episode, where we're going to really get to understanding the pain science behind osteoarthritis. So, what I say to all my episodes, the information I have just given you is my opinion alone. Please don't take what I say as a diagnosis for your condition. Please go see a healthcare professional to diagnose you the right way. If you or somebody you know has arthritis, they want to have a little bit of a better understanding, please pass this along to them. Hopefully, something I say can help them ask better questions, get better information, have a better understanding of what's going on with their body. Because at the end of the day, your health matters. Till next time, I'm Dr. Michael Chillemi. Be well, be safe. Stay tuned for the next episode. It's number 4 is coming. Stay tuned for it. Be well, be safe.